Well, welcome everybody to this Dean's Lecture. I'm thrilled to see everybody here, and we're in for a real treat today. As you all know, earning the title of professor is at the Bloomberg School represents an incredible achievement and confirms not only the respect and high regard of the school, but also of colleagues across the nation. The Dean's Lecture Series was established, and Al, did you establish the Dean's Lecture Series? You did. The Dean's Lecture Series was established by Dean Alfred Summer. We won't say when, but it was many years ago. And the purpose of it is to introduce the Hopkins community to the work of newly appointed and promoted professors, and as well to celebrate their achievements. We are pleased today to have with us Dr. Keshia Pollack Porter. Introducing Keshia is a particular pleasure of mine today and it's very meaningful because I was the chair of Health Policy and Management when we were able to convince Keshia that she should come back to Johns Hopkins Bloomberg School of Public Health and be an assistant professor in the Department of Health Policy and Management. I've had the pleasure of watching Keshia grow as a scholar, a practitioner, and a leader here at the school, in the community, and across the field of public health. Dr. Pollack Porter, I'm also having a difficult time. I know her as Dr. Pollack. She is now. And there's the Porter part. So I have you to blame. And congratulations to you, too. But Dr. Pollack Porter is an internationally recognized expert in advancing policies that create safe and healthy environments where people live, work, and play. Her research has identified risk factors for and policies to prevent injuries across a broad spectrum of activities and environments, including workplaces, in play areas, during sports, while walking, bicycling, just about anything you do in the normal course of a day. Central to her broad investigation of injuries is her commitment to exploring how the social determinants of health contribute to injuries and, in turn, exacerbate disparities in injury. She has become a leading figure in the injury control research and practice community that I can attest to personally. But her injury work really only begins to define who Keshia is and what she cares deeply about. She leads the school's work in the area of health in all policies and has become an expert in the application of health impact assessments, or HIA, to assist decision makers in recognizing the potential health impacts of proposed non-health policies. Her work has helped policymakers and the public better understand the health implications of policy, ranging from national agricultural policy to local transportation policy. In recognition of her expertise in the area of health impact assessment, Keshia was asked in 2014 to serve as an interim director of the Health Impact Project, which is a collaboration of the Robert Wood Johnson Foundation and the Pew Charitable Trust. And I remember I was quite concerned that she might become the permanent director of this project, and fortunately, we were able to convince her to stay here at Hopkins. She's widely sought after, as you can imagine. Dr. Pollack's commitment in furthering the application of health impact assessments reflects her intense desire to translate research findings for policymakers and make sustainable improvements in the health of the public. Keshia joined the Department of Health Policy and Management in 2006 as the Leon S. Robertson Career Development Chair in Injury Prevention. She was promoted to associate professor in 2012 and then to full professor in 2017. Over the past several years on the faculty, she has contributed immeasurably to the department as well as to the school. She currently wears many hats. And just to give you some of those hats, she is director of the Institute for Health and Social Policy and co-director of the JHU University of Pompeu Fabra Public Policy Center. She is also director of the research core of the Center for Injury Research and Policy, director of the Occupational Injury Epidemiology and Prevention Program, and is a member of the leadership team for the Center for Health Disparity Solutions. She has also been a terrific advisor and mentor to countless numbers of doctoral and master's students, and is recognized by the Student Assembly several times, receiving advising, mentoring, and teaching awards. She is also committed to effective mentoring of young faculty. And I realized this, and I figured she really didn't have enough to do. So I asked her to become the inaugural Associate Dean for Faculty Development starting July 1, and we're just thrilled to have her in that position. In this role, she will devote dedicated effort to developing initiatives to enhance the faculty experience, maximize productivity, and promote retention. Dr. Pollack Porter received her BA in Sociology and her certificate in Community Health cum laude, highest thesis honors from Tufts University, an MPH from Yale School of Public Health, and a PhD in our own Health Policy and Management Department. Before returning to HPM as a member of the faculty, Keshia was a Campbell Collaboration postdoctoral fellow in evaluation at the University of Pennsylvania that was in collaboration with the Robert Wood Johnson Foundation. In recognition of her many, many achievements, Keshia has received numerous honors and awards. Just to name a few, she received the JHU just last year, the JHU Distinguished Alumna Award, the APHA Injury Control and Emergency Health Services Mid-Career Outstanding Service Award. And in 2011, I think this is the coolest honor. In 2011, Keshia was named as one of Maryland's very important professionals under 40. In preparing these remarks, I was certainly reminded of how remarkable Keshia is as a researcher, as a teacher, and as an advocate for those most vulnerable in our communities. As someone who has seen her grow over the last several years, it is a distinct pleasure to invite her to give today's Dean's Lecture. Please join me in welcoming Professor Keshia Pollack Porter.
Thank you so much. I really appreciate it. Thank you. Good afternoon, everyone. Thank you for applying. Appreciate it. I'm just so thrilled to be here. I want to just thank Ellen for those wonderful, humbling comments, and just say that I love working here. It's a blessing to be able to use my God-given talents to make a difference, and I'm just grateful for the opportunity to share an overview of my work today. Ellen told you a little bit about my background, and I have lots of pictures today. So hopefully, if you're on this side, you're not missing too much. You might want to move to the other side of the room. But as Ellen said, I went to college at Tufts undergrad, and I just want to highlight that in terms of what we see here on the slide, in terms of all the places where I've worked, going to the Robert Wood Johnson Foundation and Penn for my postdoc was really transformational for me. I had trained here in injury epidemiology. My thesis looked at the intersection between injury and obesity in the workplace. And going to RWJF, I learned how a foundation thinks about evaluation, how to tell stories in terms of your impact, had an opportunity to travel around the country and meet grantees, and I loved being essentially a program officer, but I missed doing my own work. And that was what motivated me to apply for faculty positions and to come back here at Hopkins. And I'm not going to shout out too many people throughout this talk because there's a whole host of individuals who've been influential in my career, but I do want to mention Shannon, who was at a RW, I don't even see Shannon, but I know there's Shannon, who was actually at a SAPRI meeting for RWJF when she learned about this postdoc, and she came back and told me about it, and I applied, and I would have never have heard about it. So I'm grateful for that because that experience really shaped my career in terms of especially the long relationship and fruitful relationship I've had with RWJF since then. As Ellen said, I was hired here in 2006 as a Leon S. Robertson Faculty Development Chair in Injury Prevention, and that's a picture of Leon, the donor. I met him last year down in Nashville, Tennessee, to stay connected, to let him know how things are going. And Leon and I had a great time, and just wanted to share that photo. Ellen mentioned that I have a number of center affiliations. I'm showing them here. And I'm grateful for all the opportunities to make an impact and to be in leadership in the Center for Injury Research and Policy, in the ERC for Occupational Safety and Health, in the Institute for Health and Social Policy, and the JHU UPF Public Policy Center, and the Center for Health Disparities Solutions. When I came back from RWJF, my time here as a Leon Robertson Chair, it was really fortunate for me to be in that chair because it allowed me to have time and space to develop some areas that had started to percolate when I was doing my postdoc. So at RWJF, I had the opportunity to sit on the childhood obesity team, which at the time, RWJF had invested about $40 million to address the childhood obesity epidemic. And I was able to bring the perspective of an injury scholar who thought about safety and pedestrian injury and safe routes to school to that work. And I remember coming back here and early on as assistant professor, I remember talking to Daniel, and I was sitting in my office about all the work I was doing, and he advised me to have a broad enough umbrella that I could do all the things I wanted to do, and I did. And that's how my umbrella came up being advancing policies that create safe and healthy environments where people live, work, play, and travel. And so I'm grateful to Daniel for that advice, because I didn't feel like I needed to hone in on just workplace or just the community, but I was able to really have a breadth of work under this large umbrella. My work falls into these 4 buckets, and today I'll tell you a little bit about some projects I've done under each and how excited I am about some ongoing things and future things in each area. I'll tell you about how I define where people live and some things going on there. We'll talk about work, efforts to encourage safe play, and travel. Ellen mentioned that one of my overarching themes is translating research to policymakers and making sure that what we're doing is evidence-informed and that we really close that gap between policymakers and researchers. And that experience or that perspective for me was informed of the time I spent in the Maryland General Assembly when I was a doctoral student as an intern, working on staff for Delegate Dan Morheim at the time and really learning about the policy process in the state. And when I joined the faculty here, Shannon and I together volunteered on Delegate Morheim's staff for a number of years and wrote some papers together, also highlighting how we could use science to inform the policy process. The other theme that's really important to me is addressing the social determinants of health and advancing health equity, and I'll come back to that throughout my comments today. So let's start with where you live. A lot of my perspective on where you live is really guided by this quote from Dick Jackson that many of you may be familiar with, where he basically said, "We've forgotten that much of our health is dictated by where we live." And that, for me, really emphasizes the importance of the social determinants of health, thinking about our homes, our transportation systems, our access to food and schools. And the fact of the matter is if we know that those factors influence health, decisions about those sectors are not being made by the health sector, right? So if we think about the influence of housing on health, it's the housing sector. Or schools on health, it's mostly the education sector. And so I find challenging to address those issues and interact with those sectors. So one way that I've been able to do that is really advancing health in all policies. The acronym for health in all policies is HIAP. And the work that I've been doing around HIAP is really advancing this mission. And HIAP is a systems level change. It's a collaborative approach by which we connect sectors. We change the way that business is done to encourage health and considerations of equity before decisions are made. In Maryland, there was legislation passed in 2017 that actually created a health and all policies work group that I sit on. And part of my role in this work group has been to help different agencies in the state come together and think through how the decisions they're making are affecting the public's health in Maryland. We have continued to meet since that bill was passed. We met in 2018 and we're finishing our work now. We delivered a report to the General Assembly in January, and we're moving into implementation now, again, to help various agencies in the state come together and think through how decisions that they're making are affecting health and equity. Ellen mentioned that I have an expert in health impact assessment, which is really one way to advance health in all policies. And my interest in HIA really began about a decade ago, where I was first exposed to HIA through some readings and at a conference. And I went and got trained by experts at the CDC who were really leading the growth of HIA in this country. I did my first ever rapid HIA, which is a quick analysis on a living wage bill in Maryland, testified on that bill with a student who worked with me through the PHASE program, and we highlighted how that bill could affect health. I was so grateful, and I looked to Janet. I received a Faculty Innovation Fund Award in 2010 that really propelled my research in this area. And it's funny because when I was looking back at the year that I got that, I realized that Jeff Leake, who just gave his talk a few weeks ago, got one the same year as well. So if you haven't got an FIF, get one. It'll be really great in terms of your career. But I'm grateful that we have these pilot funds available at the school to explore new areas, because prior to me doing this work, I really was not perceived as somebody who was a leader in HIA. I wasn't yet. But through research, I led the first ever evaluation of HIAs in the country. And ultimately, that led to being asked to be a reviewer first for the HIA report that set the standard for practice in the country, and then being invited to do work with the Health Impact Project, which was started around 2011. And Shelley Hearn at the time was the health director for Pew, and she called me and said, "RWJF is starting this new program. Would you like to come and work here?" And I said, "Well, I don't want to leave Hopkins, but you could support my time, and I could do work with you guys and help really advance and optimize the use of HIA for policy decisions." And that began my long relationship with the Health Impact Project. So my work on HIA has really been around practice of HIA. So we've completed HIAs on a number of federal bills. We've looked at proposed changes to the Supplemental Nutrition Program. We've also looked at education policy, a food policy, housing policy with HUD. And I highlight these because all of these bills, when they came up at the federal level, they were not talking about how these changes could affect the public's health, could affect equity. So our analysis, our dissemination to policymakers really helped to elevate how health could be affected if these decisions moved forward. I also put up here the emblem for the National Prevention Council, which was formed through the Affordable Care Act back in 2010. This group, I had an opportunity to brief them a couple of times, and actually my interactions with them, along with some other things that just converged at the right time, led to this last particular HIA that we worked on with HUD to really look at a new rule that they were proposing around how they were designating housing for seniors and for people with disabilities. So again, I just want to show you how my work in terms of the practice of HIA has really helped me to excel in this area and also really inform my scholarship. So not only have I been doing work in terms of doing HIA, but also advancing research on HIA. And here's just a few headings from some different papers. I created a class on HIA many years ago. It's going great. I just finished third term, had 60 students, teaching young, eager public health folks how to do HIAs. And back in 2013 or so, which was the second year I had been teaching this class, there were only about 5 courses of HIA across the country. So I reached out to the other individuals at various institutions and said, how are you guys doing your course? And we came together and decided we would develop a model curriculum. So we published a paper about how do you teach HIA in courses for graduate school. And I would say I've had people contact me after and said that they've used this to develop their curriculum in terms of how they're teaching HIA for their students. Ellen mentioned that I was the interim director of the Health Impact Project, which is at Pew. And in that role, I was asked to really reflect on the field. I've really enjoyed being that senior author on various papers related to HIA. And this one in particular, we were asked to reflect on the field in the last 7 years. This is the time after I came back to Hopkins after being the interim director. And we were able to say, well, where does the field need to go? And really sort of saying, where do we need to make advances? Where are the sectors where we're really falling short in terms of HIA? Where do we need to be in terms of training practitioners and training communities to do their own health impact assessments to advance equity? I've continued with my work around evaluating HIAs. Here's a paper that was recently published last year in Journal of Urban Health, where we've documented using a national mixed methods evaluation how HIA is influencing determinants of health and health equity. That evaluation continues, and we look forward to releasing some more findings. And what's so important about this is whenever I talk to policymakers about HIA, they say, well, where's the evidence? Where's the evidence that what you've said to me could happen is actually happening? This work and other work has really helped us to fill that gap in terms of showing policymakers the value of HIA for decision making. We're also tracking legislation in this country. There's been a number of states that have proposed HIA legislation. Some have requirements for HIA. And we, with some colleagues at the Temple School of Law, did an analysis of HIA bills that have been proposed and passed. And I want to just highlight that actually in Maryland, there's been some efforts to advance HIA legislation led by Delegate Robin Lewis, who proposed a bill last year that would require decisions out of the Public Service Commission to conduct HIAs. The bill did not even get out of subcommittee last year. She reintroduced it this year, and to our great surprise, it's gotten out of subcommittee. It got out of committee, and it was actually voted on in the House, and it's gotten out of the House, and now it's on the Senate side. And what's really exciting about this is after I testified at the hearing this past February, we were in the hallway, and Delegate Lewis worked here at Hopkins, actually, for those of you who don't know. She's an MPH from Columbia. She said, Keshia, I learned about HIA from you, sitting in Hampton House Cafe, talking about this tool. And she said, if I hadn't learned about it at that time and had this conversation with you, and if you hadn't given me these tools, I would have never known the power of this for public health. And so to see that potentially coming to fruition now has been great. My students actually helped pull together some materials for the bill hearing that were referred to during the hearing. And again, we're excited to see what happens with the bill on the Senate side, and we'll know more in the next couple of weeks. We'll actually know this week if it gets assigned to a committee. But nevertheless, we're really excited that for the first time, this bill will require, before a permit is given to somebody regarding a utility project, they can't only think about the aesthetics of that. That's really what the bill says. Think about the aesthetics. Now they'll have to think about the health impacts as well. One other area related to this work on health and all policies is something I'm usually pretty humble, but I will say this was a pretty great idea. So I had this great idea to do something called a health note. And I thought about this in Annapolis when we were working with Delegate Morheim, because the rapid HIA was still a little too much. We needed something even more succinct. And so what we ended up doing with my colleagues at the Health Impact Project is applying principles of an HIA to say, let's create a health note. Just like a bill gets a fiscal note, let's give it a health note, where we are documenting the potential health impacts of that bill. We're not making recommendations regarding legislation if it should pass or not, but we're completing these notes in about a week and really targeting state legislatures right now, but some localities are interested as well. We are in the middle of a pilot focusing on the bills coming out related to housing, employment, education, and land use planning. We published one bill in Colorado during the legislation. We did another one this year in Colorado. We've published two in Indiana on bills from Indiana. We're working on a third one now from Indiana. And we are actually expanding to 3 new states through a partnership with the Center for Budget and Policy Priorities. Really excited. We'll be moving into California, North Carolina, and Ohio this year. And I have to say there's been some early success. The legislator in Indiana cited our health note on the floor in terms of testimony for a bill, and the data we were able to provide that again showed how a bill that had nothing to do with health on the surface really was going to have significant impacts for public health. So that's where we live. I'm gonna tell you a little bit about where we work. And my work in this area has included a number of things. Most recently, I do a lot of work with Major League Baseball. And you might think baseball, well, athletes are employees. They might get paid more than we do, but they are employees. There's a union. They are workers. There's contract negotiations. And it was many years ago when Ellen was chair, when I went to Ellen, and I'm thankful to Ellen for this, and I said, there's this thing that might develop. I don't know where it's going to go. And Ellen encouraged me to see where this relationship would go with Major League Baseball. And ultimately, I helped them develop a new injury surveillance system. At that time, every team was doing their own thing. So this was the first ever league-wide surveillance system called HITS. And it's actually connected to the EMR. So we have EMR for all baseball players once they are recruited into the minor leagues, all the way till when they retire. We published a paper about this in the American Journal of Epidemiology, and I'm incredibly grateful to Frank Carrero, who is my main collaborator on this work. And we have really been moving forward with work around baseball. And so I sort of say, nearly hundreds of thousands of dollars later that they've poured into the school, and we've had about 10 papers. It was clearly worth my time. So thank you, Ellen, for encouraging us to, or me to pursue this relationship. We've published a number of papers on all kinds of injuries. We actually have this really interesting prospective cohort study going on now where we recruited minor league pitchers once they were in the league, following them over time to see how their injuries are affecting performance. I will say, despite all these papers, the real citation that was most exciting to me was in the sportsillustrated.com in 2013, where this, if folks know, if any baseball fans in the audience, you know that baseball had a rule change in terms of sliding into home plate. So this article says, the MLB Rules Committee voted to ban collisions at home plate. The rule was in response to recent concussion studies. That's the work Frank and I did. And so it doesn't say Johns Hopkins, but this is like my pride. Like, I'm super excited that we got shouted out in SI.com back in 2013, and that our work really helped to reduce the risk to catchers, because we found that catchers were disproportionately being impacted by concussions. You don't think about baseball as a contact sport, but again, we saw this increased risk of head injuries to these players. So that was just an example in terms of where we work. So I'll tell you a little bit about some work I'm doing in terms of where we play. And in terms of where we play, I will again reference the Robert Wood Johnson Foundation, who did something very interesting. A couple of years ago, they put out a call to about 20 researchers in the country to say, you know, we're looking for some new ideas related to physical activity, equity, and you know, you don't have to tell us exactly what you're going to do, but tell us how you would go about identifying the need in the field. And 4 of us who were on that email decided to partner together. And we received funding from RWJF, and they branded us PARC. So we were the Physical Activity Research Center, so the 4 of us. And we basically developed a new agenda for physical activity research. And I'm not a physical activity researcher, but I'm an injury researcher who brings that perspective to physical activity. And so I had a very unique perspective that I brought to this particular collaboration. And through a process by which we identified needs in this country in terms of children who continue to be unable to find safe places to be active, we created a study that focusing on rural communities. So I had never done anything in rural settings before this, but I reached out to a colleague at Baylor who's been my co-PI on this work, Renee Umstead-Meyer, and we have actually been helping to promote an intervention called Play Streets. Play Streets has its roots in urban environments, so think about closing a street to traffic, where kids then have an opportunity for safe places to play with no concerns that parents have about traffic. It started in New York around 2010. Chicago's been doing this since 2012, where I'm actually evaluating Chicago's program in a separate project. But here, the Robert Wood Johnson Foundation was interested in rural communities, and there was some data showing that this was a promising intervention, but had never been implemented in rural settings. And so Renee and I embarked on this journey together, where we implemented and tested Play Streets in rural communities. And the reason why this was so significant is that if you think about rural settings, we think about lots of open fields, but the fact is that individuals who live in rural communities face unique challenges to being active, right? So there's actually a lot of communities that don't have sidewalks that promote walking. They're also lacking bicycle lanes and other types of built environment features. And so we thought, well, we can't always have these permanent changes. Play streets are temporary. You close a street for a few hours, and then you reopen it, and you do it again another week. And if you do this over time, you could create a culture of safe play, a culture of health that promotes changes to the built environment, where we're reclaiming streets and taking them from cars to say, let's go ahead and allow kids just to be free outside. So we engaged in a number of formative research where we did systematic reviews and looked at the gray literature to understand how to actually implement these in communities. We had a number of calls with organizers of play streets around the country. We spent some time in Chicago and visited play streets to learn how they were being implemented on the ground. And then we decided, how do we identify these communities across the country to do this? We spent a lot of time trying to find the right partners. Ultimately, under our big PARC umbrella, we focused on low-income communities, rural communities across the country. We decided to really be feasible in terms of geographic spread, and I'll show you a map in a second of where we ended up working. And we focused on 4 communities in this country who were ready, quote unquote, to implement play streets. So they'd never done it before, but they had experience and they were credible organizations in their communities. So we thought, well, let's just teach them how to do this. They're already doing other things in the community. We sought racially and ethnically diverse communities, and we used our existing networks, and we're grateful. Beth Resnick is sitting here. I don't know if you remember, you connected me with the Garrett County Health Department, which ended up being one of our sites for this work. We spent a lot of time going to these communities, part of building trust, part of building relationships so that they would recognize we weren't just coming in to do some intervention and flying out. And some of that involves our community in North Carolina is one of our sites. It's a church. I remember flying down there, and we're in pretty rural places. So fly to Raleigh-Durham Airport, drive 2 hours, spend 15 minutes meeting with the church leadership, and then turn around and go back home. Or we flew to Oklahoma City. One of our communities is a tribe, Choctaw Nation of Oklahoma. You drive the 3 hours, go to the tribe, and you meet with the tribal elders. You meet with the IRB to get buy-in and permission, and to meet with the community in terms of helping them see how this intervention can really advance their own goals in terms of improving the health and community of their residents. So we worked in Texas in a predominantly Hispanic community, in Oklahoma with this tribe, with the Choctaw Nation. We worked in Warrenton, North Carolina with Coley Springs Baptist Church, and with the Garrett County Health Department in Oakland, Maryland. We basically gave them some seed money because Chicago was giving communities money to do their play streets. So we replicated their process a bit. So we gave each community $6,000 and said at least $1,000 had to be used to buy equipment that you could use again. So balls, hula hoops, etc. They were each asked to target kids and families in elementary and middle school. We gave them some resources and some technical support. We collected a lot of data on physical activity, community impacts, how this was affecting social cohesion. And actually, we had a few of our communities do this again last summer. So we collected most of our data in 2017, and some communities replicated this in 2018. I'll say that play streets are a great intervention in the summertime when kids are out of school, where we know that data shows that they're less active than they are in the school year. So it's really filling an important gap for kids. Here are just some pictures. One of the things I'll tell you is that play streets in rural communities are really not on streets. Why is that? Because sometimes there's only one street in the whole community. You can't close that street down. And so what we had is communities really taking advantage of spaces that were not being used, public spaces where people were not going, and turning it into places where for 3 or 4 hours once a week, community members would come for free opportunities for the kids to play. They did all kinds of things. This particular picture on the bottom is actually of a housing community, a low-income public housing authority where the play streets were done right outside of that community on the street and on the field. Every play street had massive bounce houses. Kids love bounce houses. And so this is one from Oakland, Maryland, where it was a beautiful park that wasn't being used. There were tons of kids living by this park who were not going into this park. When we asked, they were like, this park isn't for us, like it's for the tourists who come to Garrett County. And they didn't really see this as a place for them to go and play. And so we were able to work with the health department that really amplified this space, and were able to bring more members from the community to this space here so that they could be active. We collected a lot of data. I'll just tell you briefly, we put pedometers on kids as a measure of physical activity when they came into the play streets. The main point I want to highlight is that we did not find significant difference between boys and girls. And why this is so important is that there's so much data that shows that girls are historically less active than boys. We did still see the difference in teenagers, and the teenage girls they were too cool, right? They were just sitting hanging out. But the kids were very active. And the thing that we saw is that bounce houses are equalizers in terms of, it doesn't matter what sex you are, but kids are going wild on bounce houses. The other thing we learned about this work is that although we put pedometers on 372 kids, we only had complete data on 353 because pedometers don't do well when they get wet. And so they were all sealed, which means they were taped. But this was the summertime. It was hot. A lot of the play streets would turn into water play streets, and we would try to grab the pedometers off before the kids got wet. But we did lose just a few of the data. But again, ultimately, what we found is that when kids are at play streets, they're really active, they're as active in getting the number of steps you might get in terms of an active recess session during the school day. We also use this tool called SOPARC, which is a way of taking systematic observations of to determine physical activity levels. And we also, again, found, in terms of we're observing people, we found no differences in activity level based on sex for children. We saw that people were pretty active at the play streets. Children were more active than teens, not surprisingly. And again, male teens were more active than female teens. And I don't know if you can see this in the back, but I just want to show you. This is actually, SOPARC allows you to look at everybody's, the places where people are being active. We can look at activity level in those spaces. Over here are the inflatables, and what you're seeing here is the percent of male who are active, females, and then the teens. And across all of the areas, we just saw significant activity levels again at the inflatables. This is open fields where our teen boys were most active. And then again, use SOPARC for every single space, including where there was snacks and there was food. And I just want to highlight, a lot of these communities, kids were food insecure, and having food at these play streets was critical to provide lunches for some of these kids. We're in the middle of dissemination, and here are just some of our key messages that we found from our work. You know, we basically have been able to show that kids are active at play streets in rural communities. They are fun. We did focus groups with kids after these play streets and have great stories and drawings from them, great data. Parents talked about how this was so important in terms of being a free space to bring their kids. I remember one mom in our focus group said she had 4 kids and she can't afford to bring the kids to the pool every day because it's $2 per child. And to be able to do that every day in the summer when you have 4 children is you just can't afford it. And so the benefit of having safe places that were free for kids to play was really important. We think that play streets are an effort to help support health equity. We also have great data about neighbors coming together, impacts on community cohesion. And again, as I said earlier, in rural communities, they're usually not on streets. We're disseminating right now back to the communities, to the practitioners, and to the researchers. And we just had our first paper came out on Friday, which is a systematic review from this work. And we have another paper that was just accepted. And we're just really anxious to get this work out in terms of showing and documenting how important this is. We're also creating an implementation guide that we are going to, I just had a call today we're working with Barnes Communications to help develop this guide to say, if you want to do this, here's how you can do this. A very user-friendly guide, because we do think that this is a low-cost intervention that any community can do. So that was a little bit about where you play, and I'll just talk a little bit about where we travel. So in terms of the work that I'm doing on where we travel, I've published some work looking at motor vehicle crashes in different populations, and so this was a systematic review we published in Epi Reviews a number of years ago, looking at motor vehicle deaths amongst American Indian and Alaska Native populations. I've looked at crashes in the fire service. I've also looked at the military populations in terms of identifying risk factors for crashes. Ellen mentioned biking and walking. I have a real passion for what we call active transportation, helping people walk and bike for their normal routes, and how do we do that safely? So we've studied bicycling here in Baltimore. We've also studied pedestrian safety here in Baltimore. Because of this work, I was appointed to a transportation research board committee, and we have worked on how road design can better include public health. And this work was actually really terrific because it brought together transportation engineers, transportation planners, and public health people into a room to say, let's think about how do we come forward with a research agenda. So we developed a research agenda that we have been sharing with individuals across sectors. We wrote a paper that in AJPH last year about how we can design our roads to better address public health and transportation goals. Because the fact of the matter is our transportation engineers are not getting raises based on hitting health goals. So how can we help them have metrics that matter for them that also help to promote health? And that's the kind of work that I'm involved in doing. I love this work in transportation sector because it really helps to emphasize cross-sector partnerships. Again, we can't think about transportation without working with the transportation sector. I sit on the Mayor's Bicycle Advisory Commission. I've been doing that for the last couple of years. I'm the only health person on there, and getting a chance to talk about how do we install bicycle lanes, for example, in a way that promotes equity in the city. How do we do that in a way that's safe? Don't talk to me about the scooters. I am not part of that work. But nevertheless, it's really important to think about active transportation, equity, and safety. And I'm getting a chance to do all of that and really trying to highlight these win-wins, particularly when we're working with transportation together. Because I do believe that we can advance both transportation goals and health goals simultaneously. One example in this work that I'm doing, I want to just highlight, I've been working with NCORE, the National Collaborative on Childhood Obesity Research. That's a collaboration of the CDC, the NIH, Robert Wood Johnson Foundation, and USDA. And they have a number of studies that they support. And they reached out to me and asked if I would PI a project looking at walkability. And one of the aims was related to injury. And the real question here was, well, if communities become more walkable, what does that mean for safety? What does it mean for social cohesion? What does it mean for other benefits like air pollution? So we did this systematic review, and we just finished this up. Actually, it just turned in the report on Friday. And one of the interesting things is, particularly for the injury prevention studies that were included, is that there's still this real gap between our injury prevention researchers and the researchers who are doing work in the built environment and physical activity. Again, they all have similar goals, right? So if our physical activity colleagues want people to walk more and walk safely, and they're focused on changing the environment, our injury colleagues are focused on reducing injuries, and we just don't see them using valid, reliable metrics, even working together in a way that's producing research that's going to help really advance walkable communities that are safe. So what we're doing is we really focused on metrics in this project. We are disseminating these findings to researchers and to practitioners, because the CDC, their hope is that when communities are promoting interventions that make them more walkable, they'll use valid and reliable measures to determine the impacts that we think could help generate more funding and more support. And so again, this project has been really interesting. We are going to be moving to writing these papers up and to thinking through supporting some future intervention development work. And as we sort of wrap up my time, because I told Ellen I'd be done around 4:45 to allow time for questions, I want to just say a little bit about the future in terms of the body of work that I just explained. So my immediate future is sabbatical starting 1 week from today. And I'm very excited for my mini sabbatical. I haven't taken a sabbatical since 2010, and it's a great honor that we get afforded to us on the tenure track, and I'm excited to take that. So what am I doing on my sabbatical? It's going to be a busy time with lots of exciting things. The first is that I'm a visiting fellow at the Edward J. Blaustein School of Policy and Planning at Rutgers University. So here's a great school focusing on built environment. There's no public health school there, but they have some public health researchers. They've really been advancing health and all policies statewide in New Jersey. So I'm excited to spend some time there in Jersey in April, working with researchers there and thinking about some new collaborations. I'm also going to spend some time at the JHU UPF Public Policy Center in Spain. I see Vicente here. Excited to spend some time helping to strengthen collaborations with our colleagues at UPF. We are also, with the Public Policy Center, hosting the 2019 APAM, Association for Public Policy and Management International Conference at the end of July in Barcelona. So that time there this summer will also help continue to prepare for that as well. I'm going to do a really interesting training. So the NIH actually had a competitive grant award with where they highlighted some NIH grantees through the National Cancer Institute and some CDC grantees to apply for something called the SPRINT program. And basically what they're doing is they think that researchers are a little challenged to translate and disseminate our work, and that we actually have a lot to learn from people who have like startup companies. And so actually we applied for this, and Renee and I received this, and for our Play Streets work, we're getting connected with a startup mentor who will help us think through how we can take those lessons in terms of scaling up our intervention in our Play Streets. So it's this 8-week training. We'll spend some time at the NIH, and we'll connect with this person who will help us think through parallels, and actually with the NIH folks also think through how do we do a better job of measuring the translation and dissemination of our intervention in particular. I'm going to do actually another training at the Racial Equity Institute. In my interest in terms of advancing equity, I sit on the board for a social justice organization called Human Impact Partners with a real focus on racial equity. And I think going to do this training for a few days in North Carolina will help me just continue to be up on best practices to advance racial equity in organizations, which I think will also help me as I think about my position here. And then I just will travel a bunch for some meetings and write, read, and recharge a bit. And so look forward to a little bit of a quieter time, but also, again, I'm very busy for the next 3 months. And then, as Ellen said, starting July 1, I will come back refreshed after sabbatical to assume this new position as the school's inaugural associate dean for faculty development. Thrilled and excited for this new position, excited to help think through how I can support our outstanding faculty in terms of their development and our faculty at all ranks. So with that, I want to just thank you for your time and attention today. I've left some time for questions and comments, and I just want to give an overall thank you to all of you for making time to be here, for those of you in the room I've worked with, for those of you who have really just been a blessing. I'm grateful, and I thank my husband for leaving work to come here today to listen to my talk, my number one supporter. So anyway, thank you very much, and happy to take any questions.
Keshia, that was absolutely fantastic. Let me just begin with a question. I was thrilled to hear that the legislation on including health impacts assessments in the Maryland legislature got through committee, at least through the House. So that was good to hear. And hopefully we'll hope that it's successful. But do you know of any other states that have such legislation or are considering such legislation?
Yeah, I can send you that paper that we wrote. But definitely, so yes, there are currently, Massachusetts has legislation requiring HIA for transportation decisions, so large transportation projects. New Hampshire, or Vermont, has a bill also. The issue is that we have these, as folks know who study implementation, a lot of these bills are unfunded mandates, and they haven't been implemented well. And I think the other part of it is that people don't understand, like, well, what is this HIA thing? Who pays for it? Who's going to do it? I've told Delegate Lewis that if this moves forward in Maryland, we need to do some training so people understand what an HIA is, particularly the folks in the private sector, because they're going to have to be doing them and somebody's going to have to look at them. And so the implementation of this remains to be seen, and I'm excited to think through how could we implement that in Maryland. But we're not the first state, but we're certainly at the beginning, because while there has been a number of bills proposed in states, there's not many that have actually passed.
Questions? Yeah.
Keshia, great talk, Kellogg. So one of the things that's keeping me up at night lately is climate change. And I'd like to maybe think about, with respect to resiliency and these programs that you're pushing forward, and how, with extreme events that are going to get worse with increasing temperature and increasing rain or drought, is that being considered folding it into the systems approach that in 5 years you will still need to have this, but we need to be aware of these other things, especially with the injury and other things about going out there, activity and all that. So perhaps speculating on that a little bit and what we can do maybe to...
Yeah, great question. So HIA and health and all policies broadly has certainly been discussed in the context of climate change. And so we have seen analyses in terms of the health impacts of proposals related to cap and trade, for example, or other types of initiatives. So we're certainly seeing that. In New Jersey, they're with support from the Robert Wood Johnson Foundation, they are moving forward around climate change and really thinking through how we can look at these policies through a lens of health impact assessment to say, before the decision goes forward, is this the right decision for health? Is this the right decision for equity? So I think as we continue to see more and more people doing these analyses, we're going to see more applications to climate change broadly. There's also, I'll mention, a number of us who are HIA practitioners have been writing papers summarizing HIA for different sectors and sharing that paper with that particular sector. So there have been papers published on transportation. We have one in review on housing. one on everything related to agriculture, and there's one right now under review led by Annie Dannenberg on climate. So all the HIAs that have ever been done for climate change being targeted to folks in that who work in that space in order for them to be better informed about this tool.
Thank you for your talk. I'm wondering, I found it exciting that you were sitting on the boards of mostly transportation systems. So I wondered if you share some strategies that you've used to, I guess, have your voice heard in a space that typically hasn't been thinking about public health.
Yeah, thank you, Terry, for that question. I think for me, it starts with coming and with a humble spirit, right, and also listening to our colleagues in transportation, understanding their decision-making process, their incentives, which are not aligned with ours, and thinking through then how can we have synergies in terms of in advancing our goals. Like, how can we have a win-win situation here? It's hard work, right? For everybody who works in sectors where they don't think about health, we know that it's challenging. But I think that there's opportunities to continue to move forward, because when I meet with transportation folks, they want safe systems as well, but their approach to it is a bit different than ours. And so I think we need to really think through differently, I think, transportation as a whole, how we're measuring things. It shouldn't just be focused on congestion as a metric. Why should we be focused on vehicle miles traveled? Like, I think there's other metrics that matter for health that can help us get off of the emphasis on cars to more sustainable transportation systems. But I've also learned that there is a difference in terms of when people finish school. And so I've learned that a number of our transportation engineers who have been in the field for a while really are a little bit more resistant to some of these new ideas. But now some of the folks coming out are really learning a lot about public health and have more awareness of some of these impacts and these tools. And I also spend time with them. I'm doing a lunch session with a group of transportation engineers in a couple weeks just to talk about health impact assessment and health and all policies, so they understand what we're trying to do as public health people and how that can connect with their goals.
Any other questions? Could you just take a minute and reflect on what's being done internationally? There are clearly some countries that are way out ahead of us and others not so much. But
Absolutely. And I talked today pretty much about the work domestically, but health impact assessment has its roots outside of the US and so much of health and all policies. And what we're seeing right now is that actually a lot of excitement. For those of you who are familiar with the Sustainable Development Goals, the SDGs, people are talking about the SDGs in terms of health and all policies and health impact assessment. So many of those goals connect to health. I was at a meeting, actually 2 meetings last year outside of the US, where they reflected on the SDGs and talked about health and all policies and health impact assessment as a way to really achieve and advance some of those goals.
good. All right. Well, please join me again in thanking Keshia for a marvelous lecture. And also for congratulating her on being promoted to professor. This a little ways, that was back in 2017, but but we really, it's just, you're doing fantastic work. And we appreciate all you do.
Thank you so much. Thanks again for coming.
And please join us in the atrium for some refreshments.